I'm going to begin with, we got the message recording, there we go. I'm going to begin our presentation this morning by acknowledging that Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. And now I have the pleasure of introducing our speaker for this morning, who is Dr. Johannes Roth, who's known to all of us. He is Professor of Pediatrics at Professor of Pediatrics at the University of Ottawa and Chief of the Division of Pediatric Dermatology and Rheumatology. Dr. Roth completed his medical studies at the University of Tübingen in Germany in 1996 with 1 year at St. Mary's Hospital Medical School, Imperial College in London. He completed his medical training in pediatrics and pediatric rheumatology at the Children's Hospital of the University of Tübingen. He subsequently worked as a pediatric rheumatologist at the, I'm going to mess this up, Johannes, Charité Universität Medizin, Berlin in Germany. Since 2007, Dr. Roth has been a pediatric rheumatologist at CHEO and is currently chief of the Division of Rheumatology and Dermatology at CHEO. He is a very active member on various committees and professional societies nationally and internationally, with a well-established focus on musculoskeletal ultrasound, which he has done teaching around the world. The title of his presentation is very intriguing: When Medications Don't Work as Expected, Heterogeneity in Patients with the Same Clinical Diagnosis. So welcome, Johannes, and over to you.
Thank you very much, Mona. It's a pleasure to be here this morning, and I will not talk about ultrasound today, but actually want to tell a story today of one of the patients here at CHEO who has had an incredibly challenging course of severe disease for the past 7 years, but has also shown great resilience together with her family in dealing with it. And I want to illustrate through this example how heterogeneous patients with the same clinical diagnosis can be, and discuss the wide array of advanced diagnostic and therapeutic options. Now, I want to be clear, I'm doing this as a clinician and not as an expert in genetics or molecular techniques, but I think as clinicians, it is our responsibility to explore advanced techniques and therapeutics when necessary. And finally, while doing so, we need to keep in mind ethical implications of those actions, and I want to discuss those as well. So our patient really came to attention in 2014. She was 3.5 years old at the time. She had spiking fever since February and was admitted at SickKids because she was visiting Toronto in March. She was found to have swollen lymph nodes, arthritis of knees, macular rash of neck and back, abdominal pain, but no diarrhea, no hepatosplenomegaly, and infectious and oncologic workup was negative, ANA 1 in 40 and RF negative. There was no family history for any autoimmune disease or MAS. And she was diagnosed with systemic juvenile idiopathic arthritis. Now, systemic juvenile idiopathic arthritis is actually the first pediatric rheumatic disease that was described in 1897 by Sir George Frederick Still, and that's why it's also called Still's disease. And this was a time where pediatric rheumatology consisted of rheumatic fever and nothing else. It is today diagnosed when you have the presence of 2 weeks of spiking fevers, typically in the morning or the evening, and arthritis, and at least one of rash, lymphadenopathy, hepatosplenomegaly, and serositis. Interestingly, it can be a monocyclic disease course with just one episode, ever polycyclic or persistent. When we look at the pathogenesis of it, there is an interesting contribution of the innate immune system, so macrophages, monocytes, neutrophils, and complement, in contrast to the adaptive immune system of antigen-specific B cells and T cells that we often imply in autoimmune disorders. And the innate immune system, while being the more primitive, older part of our immune system, has actually only got the well-deserved attention in the last 1 or 2 decades. And it's quite fascinating. So the way it gets activated can be either from environmental triggers, UV radiation or others, and those are called danger-associated molecular patterns, or it can be pathogens, and those are called pathogen-associated molecular patterns. These stimuli will act through cell surface-bound or intracellular receptors, and one of the big group of those receptors are the toll-like receptors. And believe it or not, there is 2 Nobel Prizes for medicine that were awarded around the toll-like receptors and their discovery in the last 2 decades. So really an important piece of our immune system. What happens then is that we have intracellular protein complexes, typically called inflammasomes, that will form. They will activate certain enzymes, and this will lead to the secretion of pro-inflammatory cytokines. In the case of systemic J, IL-1 beta and IL-118 predominantly, and those can then activate the adaptive immune system as well. I want to sidetrack here for 1 second and just to illustrate the importance of toll-like receptors, as they are also the initial entry point for COVID-19, and only after that it upregulates the angiotensin converting enzyme receptors. And variants in other toll-like receptors have been associated with severe disease course in COVID-19. So this is a very important ubiquitous receptor type that plays a role in many disease processes. Now, as you can imagine, many steps of this immune regulation may have variations due to polymorphisms that people carry, but the knowledge in systemic J and many other diseases is really limited in that respect, and testing for such variants is not part of workup for most conditions in rheumatology. Coming back to our patient, she initially had a very high cell count of her white cells, but then 4 days into admission, something very ominous happened. Her cell counts dropped dramatically to only 3,000 4 days later, and the ferritin rose significantly, CRP really went up, and markers of macrophage activation were elevated. And so she was diagnosed with systemic JA and macrophage activation syndrome. Macrophage activation syndrome, or also called hemophagocytic lymphohistiocytosis, is a condition of a massive release of pro-inflammatory cytokines, accumulation of these macrophages in various organs. And from a lab perspective, what is really striking is that drop in cell lines and a really high ferritin. And this hemophagocytosis shown in this picture, where a granulocyte is being phagocytosed, is not necessarily present in the early stages. The bigger picture is that the overarching term is hemophagocytic lymphohistiocytosis, and there is a primary form of it that comes with certain genetic mutations and will present early in life. And there is secondary HLH, which is an acquired form and not necessarily associated with genetic mutations. And that can be infection associated. EBV is a big candidate, malignancy, and also in the context of rheumatic diseases. And that's where we typically also call it macrophage activation syndrome. And in systemic JA, actually 10% of patients will have overt MAS, either at diagnosis or at some time in their disease course, but a much larger percentage will actually have subclinical features of macrophage activation syndrome. Diagnostic criteria are slightly different than in hematology. Just want to mention that so that one has to be careful not to underdiagnose this condition in rheumatology. How do we treat systemic JA and macrophage activation syndrome? Well, traditionally, we've been using high-dose glucocorticoids, but of course, this has caused a lot of problems in terms of long-term toxicity. And so people have been looking at DMARDs like methotrexate, at biologics like anti-TNF, but all of them do not work that well in systemic JA. And so it was a big relief when in the 2000s and later, new medication became available, and the two main groups of medication that we use for the treatment of systemic JA are anti-IL-1 and anti-IL-6 medications, and they're very effective. And this is shown on the right here for one of the trials of anti-IL-6. You can see on the x-axis the weeks. You can see that the patients in this trial really stayed, they adhered to the therapy, and they had an early traumatic response. These are just response criteria for rheumatology, but you can see that 80% had a 70% response, which is dramatic, and they maintained that response. So very, very effective medications that changed everything for these patients. So not surprisingly, our patient, because she had MAS as well, she received some methylpred and prednisone initially and also IVIG, but was started on Kineret and anti-IL-1 medication and was meant to be on that medication actually as the main treatment modality. She was sent back to Ottawa, and we were told to take good care of her, but really struggled with that early on, because whenever we tried to wean her prednisone, she would flare immediately. So we added other medications, cyclosporin. We switched from IL-1 to anti-IL-6, but she had a very early on severe infusion reactions to the anti-IL-6 medication. So eventually we ended up on another anti-IL-1 treatment, but we had to double dose it and shorten the injection intervals. Now, at this point, I also want to introduce the element of cost. And so these medications don't come cheap. The canakinumab, every syringe costs $16,000, and it's been given, in her case, every 3 weeks at the double dose. But luckily, the cost is kept at $96,000 per year, but that's still a substantial amount of money. Because she was so unusually treatment resistant from the get-go, we were looking at additional testing, and we were trying to understand what is different with this patient. Why is this patient not responding to treatment as we would expect it? And so we did targeted testing for mutations that have been shown to lead to HLH or MAS, and there was nothing. We then thought, well, maybe it's an immune deficiency. You know that the range of immune deficiencies has expanded greatly, and they can give rise to autoimmune disorders as well, but nothing there either. So at that point, because the pressure, I felt the pressure was so high because she was so difficult to treat, I actually went further, and we requested a whole exome analysis. Now, whole exome screening or even genome sequencing is increasingly used now, whereas in the early 2000s, the cost to analyze a human genome would have been in the range of hundreds of millions of dollars. This has come down so dramatically that now the cost is less than $1,000. But the criteria for approval funding require clear phenotype of a likely monogenic disease, which she doesn't have. She has systemic JA. We don't think of it as a monogenic disease. And the analysis, of course, is more challenging in complex genetic traits. All of us carry so many polymorphisms that if you just simply do a whole exome on a patient, you may have a range of results that are very different to interpret, difficult to interpret, especially if you don't have a family history of affected and unaffected members. So it's really important when you ask for this to clarify who actually is going to interpret the results and counsel the family. In her case, we eventually did it on a research basis at SickKids, and sure enough, we found an interesting candidate. We found an NLRC4 mutation, but that mutation was of unknown significance. So NLRC4 and associated disease has been described in 2014 only. It forms an inflammasome complex. So remember, that's the intracellular complex that is so important in the functioning of the innate immune system, and then activates the enzyme and leads to secretion of IL-1 and IL-18. But also a process that is called pyroptosis. And while you may be aware of necrosis or apoptosis, pyroptosis is another form of lytic cell death, highly inflammatory, and the purpose is to kill those cells so that they don't become a niche for microbial growth, but while the cells die, they expulse inflammatory cytokines in a violent way to maintain the inflammatory reaction. The associated disease with NLRC4 mutations is persistent activation of the immune system with fever, arthritis, HLH, and enterocolitis. So certainly some features that were clearly overlapping with the disease presentation in this patient. She did have abdominal pain as well, by the way. And this disease is called IFEC, autoinflammation with infantile enterocolitis. Now, interestingly, after the discovery of that gene and the associated disease, other mutations in the gene were discovered to cause another disease, cold-induced episodic fever, urticaria, rash, and arthralgias. And in fact, this other disease, the FCAS, or familial cold autoinflammatory syndrome, again has 4 different subgroups where they look clinically similar, but they have 4 different genes which can cause it. So once you dive into the genetic world as a clinician, you quickly realize that it's a wild world. So different mutations in one gene can cause clinically different diseases, but then clinically similar diseases can be caused by mutations in different genes. So the phenotype-genotype correlations are really interesting and really important, and that really emphasizes the role of the clinician in the whole game. Now, the big question, of course, is does our patient have NLRC4-related disease? And this is even more important because we weren't even sure that that mutation that we found was pathogenic. So the questions you have to ask yourself when you get a result like that, when you do genetic testing on a patient and you find a mutation of unknown significance, you have to ask yourself, is the mutation in the right place of the gene to have an effect? You have to ask what the prevalence of this mutation is in healthy populations, and you have to look at other family members and maybe test them to see if they carry the mutation as well. You have to ask whether the patient shows the expected clinical phenotype, and if not, you may look for other lab parameters that would typically be expected in that context, and you may want to test for them. In the case of our patient, the mutation was in the right place. The pathogenic mutations are position 330 to 450 of that gene, and hers was in 392. It has not been described in healthy populations, so that again made it more likely that it was pathogenic. But I want to mention something important here, and that is that you have to be careful what your healthy control populations are. As you may imagine, genetic testing is much more available in wealthy countries. And in those countries, there is a larger proportion of people of Caucasian descent. And so there has been a bias in that many mutations may have not been described in the healthy control populations, but the healthy control populations may have not been appropriate for the patient in question. The mother was carrying the mutation, but she was healthy. And in terms of the phenotype, we looked at whether there would be any enterocolitis, but endoscopy was normal and the fecal calprotectin was normal. And we looked at other lab features that would typically be elevated in the disease, and IL-18 was actually normal, both in the patient and the parents. So we were thinking that we probably caught a red herring here, but beyond that, the question was that maybe we didn't catch something else that we should have caught and we missed. And here I want to introduce the concept of somatic mutations. So when you have mutations at the germline level in the oocyte or the sperm, you expect all cells to carry those mutations, including the hematogenic cells, and you expect to find that in your testing. But if the mutation happens later, it may affect only some tissues, and it may affect only some of the hematologic cells. And so you need to make sure that your technique is very sensitive to detect the small percentage of cells that may be affected. If the mutation happens even later, it may not affect the hematologic cells at all. It may just affect certain tissues, and then you wouldn't find it on your standard genetic testing. You would have to do the genetic testing on that tissue. So it really depends of how clearly you think that there is a mutation, how far you go in terms of testing specific tissues. The other thing that you may consider is doing a whole genome. The exome only is 2.5% of our genome. And so a lot of intron and other mutations may not be detected. So whole genome testing would also be an option. Now, in the case of our patient, we didn't feel that we would want to go any further at this point because we didn't have that strong of a clinical phenotype of a monogenic disease. And so at this point, we gave up on further genetic testing. Luckily, she was clinically relatively stable, but on combined treatment in 2016, so 2 years into her disease, but then something else very ominous happened, and this is that she developed clubbing. And this is interesting because she had no overt respiratory clinical findings, and when we did the imaging and the chest CT, she only had very mild subpleural cysts. So typically when you have clubbing, you expect advanced lung disease, but she didn't have that. Echocardiogram was normal. And so we co-managed her with Tom at this point, but it was mere monitoring. There wasn't much that we did. And in 2017, she was actually quite well, and we were weaning off medication, but then she got an infection, a beard infection. She had lytic lesions in her maxilla and the mandible. Didn't think that it was related to the bisphosphonates that she had received for osteoporosis treatment, and went on long-term treatment with antibiotics. But then, while she had that infection, and following that infection, she actually flared with her underlying disease. And she presented with a recurrence of MAS. And now, for the first time, all of a sudden, she had very high IL-18 levels. And sure enough, a few months later, her lung disease progressed as well. There was a right ventricular strain found on the echocardiogram. And so on the chest CT in January 2018, we saw significant interval progression. A lung biopsy was done at that point, and that showed pulmonary alveolar proteinosis. So what is pulmonary alveolar proteinosis? I had never come across that before. So what you have in a healthy lung is you have surfactant secretion, and then this surfactant is being cleared by monocytes, macrophages that reside in the alveoli. And that's a very important mechanism of surfactant homeostasis, and it's regulated by GM-CSF. Now, if you have dysfunctional macrophages, you will have surfactant buildup. Proteins will settle in the alveoli, and you can imagine that the air exchange won't work well in that case. And this can result from receptor deficiency, antibodies to GM-CSF, deficiency in surfactant proteins, and deficits of lipid transport in pneumocytes. So we did tests for everything that could be possibly a cause for pulmonary alveolar proteinosis, but everything was normal. And so this pulmonary alveolar proteinosis, as it turns out, is unique to systemic GA patients, and it was observed by others also. So when you have a patient with something extremely rare, unique, you better want to find other people who have similar patients, and you want to get them together. And this was done through a social media platform for physicians, a list server for pediatric rheumatology that is frequented internationally, where people bring up their questions. And this is something that can be incredibly useful. In this case, it led to a case series of 61 patients with that complication, was published in 2019. And all of these patients presented with acute clubbing, atypical rash, high frequency of reactions to tocilizumab, abdominal pain. And the lung pathology was this really unique form of alveolar proteinosis. And what was worrying, of course, was that the survival, the 5-year survival rate was only 42%. Through that case series, we were trying to understand why these patients would get this complication. So was it the medication? Was it the age? This was because patients in this case series had a high odds ratio of developing the disease when they were young at disease onset and exposed to anti-IL-1 or anti-IL-6. But on the other hand, other patients, and the majority of patients with systemic GA on these treatments, do not get the lung disease. So what about disease activity? Were those sicker patients and maybe had more disease activity, and that was driving the lung disease? Well, not really. 35% of patients in that cohort had MAS episode, but it was typically just one episode. And in terms of arthritis, their disease activity was only 18%, reported to 30 compared to 30% in bigger cohorts. So it was actually not that high. What it may be is that IL-1 regulates GM-CSF levels and macrophage function in the lung and has a prominent role in lung maturation up to the age of 4. So maybe that's the risk for younger patients to be exposed to medication blocking IL-1. It's possible. And then maybe the increased interferon gamma signaling during macrophage activation activates those macrophages, and then they become dysfunctional. But it still doesn't explain why other young patients who go on that drug don't develop it. So there may be a secondary trigger, maybe infection or something as a driver. We don't know for sure, but definitely there is concern about the medications that we are so happy to use in these patients. And so, of course, the natural impulse would be to stop that medication, but our patient was not stable enough to stop the anti-IL-1 treatment. Instead, we focused on some other cytokines driving MAS and the systemic GA-associated lung disease. And as I've mentioned frequently before, interleukin 18 is another important cytokine. It was really high at that point in our patient. But how can you block interleukin 18? Well, there was a medication that had just become available, but not really commercially available. It was available through trials. Initially, we tried to convince the company to give it to us on compassionate use basis, but it was denied. And so we sent our patient to a trial of that medication in Montreal. And so the mom had to move to Montreal with the patient. The father remained here with the other child. So you can see how the burden on the family was really building up at that point. And she went into a trial in Montreal in 2018. She had a significant flare in the double-blind phase, and she may have been on placebo, but we were never given the information whether she actually received the drug or the placebo. And in fact, she was kicked out of the trial because there was a protocol violation in the double-blind phase. So she came back after 3 months with nothing. And we tried again to get the medication as a compassionate use approval, but it was denied again. So we continued to treat her with an insane amount of combined immune modulation, and her lung disease deteriorated further. She was on nighttime oxygen, and her daytime saturations were not great either. So at that point, we'd done the genetic testing. We said, okay, well, let's dive further into molecular characterization of her cytokine levels, and maybe we'll find something there that will help us. And so we actually did interferon testing, and we did the so-called interferon signatures. Interferon pathways are also important in autoimmune conditions, but they haven't really garnered much attention yet. And the index patient, she on the right, had elevated levels. And so definitely the interferon pathways were activated. She became a part of another case series at the NIH in the United States, and those were patients with elevated interferon signature that all had interstitial lung disease, much more prevalent than in control groups. And she was identified as a subgroup together with 7 other patients in that group to display moderate interferon signature of type 1 and 2 interferons and high IL-18 levels. And the authors, and this was published from the NIH, actually suggest that this may be a new autoinflammatory disease, an IL-18 associated PAP and MAS. And in terms of the clinical conclusions from that, of course, one would want to treat that either by adding an anti-IL-18 medication, which we had tried but were not successful, or by using yet another class of medication, and that's the JAK inhibitors. So why would we use a JAK inhibitor, and what is a JAK inhibitor? JAK inhibitors are medications, and these are drugs that will become much more prevalent in many areas, in many subspecialties of pediatrics. Those are medications that block the Janus kinases, and those are proteins that are inside the cells and form complexes with various cytokine receptors, and then are the first step to actually send the signal into the cell. So if you block the JAKs, you're blocking a lot of different cytokine pathways, including interferon pathways. And so it seems like a good method, of course, to treat her disease, because there's so many cytokines active in her case, but also the interferon pathways. And so we tried it. We did high doses of it, but she didn't respond. And at that point, and even around the decision of adding the JAK inhibitor, we did involve palliative care and also Michelle Mullen from bioethics. The last step that we took was then to say, okay, well, let's target interferon directly. And it just happened that an interferon gamma antibody had become available as a medication. And it was actually approved in the United States for treatment of hemophagocytic lymphohistiocytosis, or MAS. Now, this medication is even much more expensive than the other medications we've used so far. A single dose of that drug will cost anywhere between $20,000 and $35,000 US. And initially you treat with 2 doses per week, and then you go on weekly. So you can imagine giving $70,000 US per week. That's insane. It wasn't available in Canada. It still isn't outside of trials or special access. So we actually tried the compassionate use route again. And this time it was denied, but then we tried again, and we tried really hard, and we got it. So in October 2019, we got this expensive drug at no charge on compassionate grounds, but the company insisted that the patient be admitted for 14 days to CHEO in the initial treatment phase, because they were so worried that anything bad could happen that they wanted to make sure that we pick up any side effects immediately. And so I'm going to show a few photos of our patient. The family has told me that this is fine, and on the recording, these photos will be blurred. So because she had to be at CHEO for 14 days, she had to celebrate her 9th birthday at CHEO, and the drug did work. It initially suppressed the interferon, but as you can see on this red graph, there were a lot of breakthroughs of interferon gamma levels despite escalating doses. We treated for a total duration of 290 days, but we were not able to settle down disease activity consistently with that drug. And the lung disease progression slowed, but it didn't halt completely, and it didn't improve either. And if you look at those lungs now in July 2020, they look really quite bad. So at that point, we were really running out of options. The lung disease was progressive, and it was clear that this would eventually kill the patient, in addition to her ongoing disease activity from her underlying disease. So at this point, I want to take a break and really look at the ethics and the ethical implications of pursuing these advanced treatment options for patients, and keep pushing and pushing and pushing to try to find solutions. And I mentioned already that we had involved the palliative care team, of course, and we had involved Michelle Mullen from bioethics. And Michelle shared this publication with me from the American Journal of Bioethics. And the title is From Long Shot to Fantasy. obligations to pediatric patients and families. And so what the authors discuss here is a typical setting in a tertiary or quaternary care center. And there are many patients who come to those centers who have severe conditions, and there may be treatment options, but they're a little bit of a long shot. So even in stage 1, you have this long shot treatment option, but there is by no means a guarantee that it will work. And then, of course, the care team and the patient and the family will embark on initial actions. And the initial action could be to say, well, you know what, it's unlikely that this is going to work, we'll pursue palliative care, or it may be to pursue the long shot option. And then the long shot option will be implemented, the treatment will be implemented, and this may result in a cure, it may result in death, or it may result in neither of the two, and the patient will survive, but is not being cured either. At this stage, of course, you enter a next stage where you have to take a look and say, well, do I have any other options? Because my first long shot option actually failed. And that's a very challenging stage, because the likelihood of finding a cure will be lower at that stage. And while there may still be other treatment options, the percentage of patients who will be cured by that will be much lower. The likelihood of death increases. And so this is a very important stage to make sure, to be clear whether you really want to proceed now or you don't. And what you really want to avoid is getting into stage 4, where curative options become pure fantasy, where nobody really believes that there is a cure for this patient anymore, but these options are still pursued. And while death is inevitable at that stage, you're still throwing treatments at the patient. The pros and cons for long shot options are that some very ill children are cured, and so the long shot option is medically and ethically justified despite its potential costs. Sometimes long shot options can also give time to prepare for death, and they may provide a psychological benefit for the parents and the patient and the team, knowing all the attempts were made. But they may come with painful invasive procedures without benefit in patients who may not be able to understand, and unrealistic expectations can really stifle preparations for the child's death. This can cause profound moral distress for the team caring for the child, and of course, long shot care can dramatically increase costs of healthcare with no clear benefit. So the strategy that the authors suggest to apply is that from the get-go, from stage 1, you're very careful in probably framing the care plan as a low-odds, long-shot option to the parents and the patient. You need to lay out clinical benchmarks that can be well understood by the parents and the care team and the patients, which would indicate favorable or unfavorable clinical responses. And it's probably a good idea to introduce the palliative care component of the treatment plan concurrently with the curative options. In stage 2, when you pursue those options, you need to have regular family meetings to provide clinical updates and review those goals of care, and also regular multidisciplinary team meetings to review the goals. And you need to allow team members to discuss openly concerns, moral distress, etc. When you enter, unfortunately, in stage 4, you need to communicate with families that you're approaching the line between low odds and no odds. And you need to articulate that by referencing to the benchmarks. And for sure, when you enter stage 4, you need to disclose that to the family immediately, and you need to discuss the family's goals of care in light of this information. In our case, we had exerted all medication options at that point, and the only other option that would have been left was a transplant, a stem cell transplant. And because there was a complex, profound immune dysregulation with potentially a genetic contribution, the consensus was that it would have to be an allogeneic stem cell transplant. There were huge risks associated with that. The inflamed lung and other tissues were a huge risk for graft accumulation. So what happens when you do the transplant and you put in the graft into the patient, the donor stem cells, they will immediately go to any inflamed tissue in the body. And can you imagine what would happen to that lung, which was so inflamed if there was a massive inflammatory reaction in the lung. That was really a huge risk. And the other risk was that we may not even treat the underlying problem because there was quite possibly expression of genetic alterations on extra hematopoietic tissue. So these were long discussions, and I'm particularly grateful to the CHEO team and Donna Wall, the lead of the stem cell transplant unit there in particular. And all of these discussions were accompanied by Michelle Mullen from bioethics and the palliative care team. And those were several discussions over the course of several months. Personally, prior to this patient, I had been involved in the decision process to transplant with 2 other CHEO patients. One survived and one died early during the transplant phase. And the one I thought much more likely to survive actually died. So you can see how difficult it can be and how difficult it is to predict. Our patient went for the transplant eventually. The family was fully on board with it in September 2020, and that's her at CHEO, now celebrating her 10th birthday again at hospital. She celebrated her 9th birthday at CHEO. She celebrated her 10th birthday at CHEO. And she did get significant graft versus host disease. And this was finally settling on another check inhibitor, ruxolitinib. And this is not something that has been done for a long time. So she may have been lucky that people are now using ruxolitinib for graft versus host disease. And I understand she's the first patient at CHEO with graft versus host disease treated with ruxolitinib, a check inhibitor. And in April 2021, 7 months after the transplant, she improved in her oxygen requirements and she returned to Ottawa just this September. And that's her on the right returning. And what was really striking is now that she's just had end of September her follow-up chest CT, and you can see on the left side pre-transplant, and now 1 year later, there's a dramatic improvement of her lung disease shown on several planes here. There is still some ground glass fine interstitial changes, but it's dramatically improved. Now, these may be chronic changes. There may be fibrosis that will never go away, but certainly there is a most dramatic improvement that we've seen in this patient. But the big question is, of course, how does the patient feel now after all of this? After 7 years of intense, often painful treatments, of celebrating birthdays in hospitals, of being away from the family and home for prolonged periods of time. And with her, it's actually sometimes difficult to know because when she's at the hospital, she won't often talk very much to us. But I have to thank Sarah Croach and Marie Lefebvre for really being incredibly supportive all along. And I think she's doing quite well. On the left photograph, you see her celebrating her 1 year post-transplant. And on the right side, as part of that celebration, you see her doing the all-you-can-carry challenge at Chapters. I didn't know that existed, but this is the all-you-can-carry challenge at Chapters, and she was very happy about that. So in summary, with patients like this, you need a strong interdisciplinary team approach. These are not rheumatology or respirology, but interdisciplinary patients, and I cannot emphasize that enough. You need involvement of psychology, palliative care team, and bioethics. And you need a good joint decision-making process all along with the family and the patient as appropriate. But I also want to emphasize that you need to consider including these patients in case series and registries, because most of the time, each of us will only ever see one of those patients in their lifetime. And in order to understand better what is going on with these patients, you need to bring them together with other patients. And then you may get a better understanding of pathogenesis, but also treatment options. And our patient has been part now of 4 publications so far. The other aspect is that whatever you do in pediatrics, there will be an increasing classification of patients based on molecular characterization, that's for sure. But at the same time, we're still very much at the beginning of that. And while some of the results that you get through genetic testing or molecular characterization of inflammatory pathway or others may inform treatment selection, these treatments may not always be successful, right? We tried the check inhibitor because we thought it was a good idea based on her cytokine patterns, but it didn't work. The key for all the diagnostic efforts, so, is the precise phenotypic and clinical characterization. So history and physical exam and the role of the clinician are really important. You cannot apply these molecular techniques in any useful way without having a very well characterized patient. We have to be aware that there are many genetic and molecular alterations at the tissue level that we may not capture when we do our regular testing. And unfortunately, we also have to be aware of the fact that therapeutic interventions on cytokine pathways that we now do all the time and that have helped so many patients may lead to unwanted alterations at the tissue level, for example, macrophage dysfunction, and they can cause severe complications for some patients. And with that, I want to thank the multidisciplinary team for that patient, including the whole entire rheumatology team, Tom and the respirology team, Leanne Ward, the bone health team, Michelle Mullen, Christopher de Bonker, Megan Doherty, for the palliative care team, Marie-José Lefebvre and Sarah Croach, and the post-transplant hematology team at CHEO. There was significant involvement of rheumatologists, geneticists, hematologists, and respirologists at SickKids. The rheumatology team at Saint-Justine in Montreal took care of her while she was on the anti-IL-18 trial. There was very significant involvement of Scott Kenna at the time he was at the NIH, and Rafaela Goldbach-Mansky, Vivian Sapper in San Francisco, and Fabrizio De Benedetti in Rome, and also the medical team at the company who provided emapalumab, the anti-interferon gamma antibody. And that was by no means easy for them either, because the company is running a risk when they provide this medication as a compassionate use basis. So all of these have really contributed to the journey of this patient. And this is a dream catcher that she made for me, and that is my office, and hopefully will protect her as well. Thank you very much for your attention.
Wow, thank you very much, Johannes, for a really fascinating presentation. You really walked us through it. It was so amazing. I mean, you really brought the compassion, the medical science, the medical understanding, the communication aspects. It was really, really a great presentation. There are already a couple of questions. If anyone else has questions, please raise your hand with the reactions button, and we'll go to Daniela first and then Tom Kovesi.
Thanks, Johannes. That was truly outstanding. Like every good presentation, I think it raised more questions than provided answers, which I think was intentional. So first of all, at first I thought, yeah, I'm giving up on the fantasy part, but then you presented basically that the patient in the fantasy phase was rescued by the transplantation. So I don't know if you want to comment on that, but this is kind of a fantasy coming true for now. The second question, would you be willing to give a second presentation on the role of stem cell transplant? Are we considering this too late? I always think in some of my neuroinflammatory patients that we should consider it earlier in the disease course when they're not that polymorbid, and it may even be cheaper in a way than all those very expensive new treatments.
Yeah, thank you for those questions, Daniela. So when we came to the question of the stem cell transplant, that was exactly the question. Are we in stage 3, where there is still a possibility for cure, or are we in stage 4, where it's pure fantasy and there is no way that this will cure the patient? The patient will undergo a very painful, traumatic treatment and has no chance of a cure. If we would have thought that we were in stage 4, we would not have proceeded with the transplant. We thought, after careful consideration, that we were still in stage 3. And the other component here is that the family clearly wanted to go ahead with that, with a full understanding that the odds are relatively low that this will work and there will be strong complications. But do we know for sure whether we were not in stage 4? No. And that's why I mentioned that, I had been involved in 2 other patients and one of them died. That's a 50% failure rate in my assessment of the situation, right? So it's very, very tough. to your question, but the only way to deal with it is really to have this approach. And we're so fortunate to have bioethics here and also a strong palliative care team. So the important thing is to follow process here. And I think the suggestions that this publication makes in terms of following process from stage 1, not just at stage 3 or 4, is really important. To your question of the transplant, yes, that's the big question, right? Those patients who go for transplant always go too late. They always go too late because we are afraid of the transplant. The transplant is a way of no return. Once you start it, you cannot return, and the patient may die. And the mortality rate is still higher than what we typically have in other conditions. And this is what makes it so tough. So there is no good solution to that, except, again, to really consider that relatively early on, if you think that you may have to consider it, and involve the transplant team early on. And then try to find a good solution for that individual patient. But yes, there is no clear answer to that, unfortunately.
Thanks.
Next question to Tom Kovesi.
So Johannes, thanks for a fabulous presentation. I'll add a 25 cents worth on pulmonary alveolar proteinosis, if that's okay. So PAP is one of those classic lung diseases, and it's a disease where you've got abnormal trafficking of surfactant in the alveoli. And it's either due to congenital abnormalities in surfactant metabolism, or it can be autoimmune, where you make anti-CSF antibodies, so the macrophages can't soak up surfactant the way they're supposed to. And PAP has really classic CT and BAL findings. So on CT, you have what's called crazy paving. And if your house has paving stones on your driveway or in the patio, and you've got light ones and dark ones, that's what crazy paving looks like on a CT scan. And when you do BAL, you get this soup of sort of milky liquid that's full of undigested surfactant. And in this patient's case, her CT did not look like PAP, and her BAL did not look like PAP. And we did her lung biopsy, and it was talking about patchy PAP. And it was the equivalent of taking your dog to the veterinarian, and the vet says, no, this isn't actually a dog, it's a very small hippopotamus. It just didn't make any sense. And then Johannes went on to speak to these groups of rheumatologists who were all reporting short groups of patients who were very, very similar to ours. And Johannes came back to me and said, you know, Tom, there's nothing published, but this is a really high mortality rate. Which is a kind of a hard thing to work with. And then gradually these two case series came out, which were just identical to our patient. And the really striking thing is that this, first of all, this new patchy PAP is a new condition. This did not exist in the past period. And it seems to be very much associated with the use of these various cytokine inhibitors in the past couple of years. And so these changes in sort of inflammatory regulation seem to play a really, really important role in this. And the final piece, just to give kind of an epilogue to our patient now, clearly her CT is better. Her pulmonary functions still have a way to improve. One of the things we could lack in pediatrics is good pulmonary rehabilitation. So if she was 80 and she had COPD with lung function, kind of like where hers is, she would be off at the rehab center doing a rehab program to strengthen her muscles and decrease her requirement to breathe while she's doing activities. And that simply doesn't exist yet in pediatric respirology, but it's certainly one of my dreams that at some point that will come about.
Thank you, Tom. That was worth a lot more than 25 cents of value there. I don't know, Johannes, if you want to respond to Tom's comments at all.
No, I think this is perfect. And you know, from the get-go, I made it very clear that I'm not trying to be a respirologist or a geneticist here, and that this is the point, right? You can only take care of these patients in an interdisciplinary fashion. But the point Tom was making at the end, these rehab efforts, I want to support that. And we were talking about all these advanced treatments and spending $100,000 and $200,000 and $300,000 a year on medication. We have to spend a little bit of money also on other aspects, including rehabilitation, because they're equally important for these patients.
Yeah. You really demonstrated the importance of bringing the skills of different experts, different professions together for the sake of the patient. That was a really great demonstration. Next question goes to Emanuela Ferretti.
Hi, Joseph, thank you so much. Sorry, I don't have the video, but I really thank you so much because you made me think really hard. Well, about one thing is a comment more than anything else. How lucky some patients are to meet with some physicians that they do not, give up in terms of try to find answers, try to find a cure and everything. And it makes me also understand that many years that I'm working on neck, which is as you know, is a terrible pro-inflammatory disease. And with my research team, not long ago, I found that actually neck has the IL-17 expression, that is the 17F form actually, that has been already reported in Crohn's disease, which is an adult disease, well, an older child disease, an adult disease, is a chronic disease, and there are many medications that obviously we cannot use in neonatology yet, right? But your presentation made me give me hope that one day we're going to be able to cure this disease that has multiple aspects, like, and it can be as complicated as yours, because for me, my patients, they die, sometimes unexpectedly, and some of them respond to the little medication that we can provide, right? Mainly antibiotics, really, antibiotics. And the other thing, it's more a question that I have for you. When you were in the stage 3 of, from that algorithm, long shot to fantasy, did you feel that, because in the algorithm you said that at one point there is time to deal with the probable death of the patient, right? But there is always a component of hope that we as physicians, we have, and you see in this case, the fact that now you can use another medication that was not there probably when she was at her 4th birthday, and so what is your take on that? When is the balance at one point in which you really, I always think, okay, am I fantasizing on this, or I still hope for a cure, I still hope for a turnaround?
Yeah, I think the answer to that is you don't want to take those decisions by yourself. Again, you have to take that as a team, and you cannot take that just with a team of people from your own subspecialty. You need people from other specialties and bioethics and palliative care in there early on, because they give a different perspective. And the fact that you're talking about possible death doesn't mean that you don't have hope for cure. I think that's what the authors are trying to say as well. When you go for a long shot, you're still going for cure, but you have to introduce at the same time the possibility of death. Anything else is not honest. And it creates this terrible situation where there's a lot of moral stress, because the parents believe, yes, we are doing something, we are curing this patient, but the team is not so sure. And this disconnect cannot happen. So you need to do it in parallel, but you don't need to do it on your own. And just for your comment on the neck, this is extremely interesting. And I wouldn't count off those medications. I mean, use those medications after birth. These anti-inflammatories. We have conditions that present in the first month of life, inflammatory conditions. So I wouldn't count those medications off, and maybe speak to our GI colleagues. They have early onset inflammatory bowel disease. Maybe there is an avenue here to use some of those medications, even in your world.
Thank you, Joseph.
Okay, next question, Anne Family.
Hi, Johannes. I'll echo everybody's comments in terms of thanking you for this this beautiful story that luckily had a nice ending, or at least a continuation. So far, yes. But I think I have 2 comments. I really enjoyed you presenting this patient as so it's not just a complex patient, but really a patient that requires intersectional or multidisciplinary care. And I think that's the future model of maybe the way we care for patients. I think we all can think of patients in our own different specialties or disciplines where they're not the typical, they don't fall into a specific box. I know there are some institutions that have this model where they have a dysregulation team, for example, or an inflammation team. And so they kind of, it's a bit broader, and it encompasses a variety of different specialties and experts. So, and to mobilize those resources, again, with the, psychology, ethics, social work, and other non-traditional, I wouldn't say non-traditional, but other experts as well in the care of these patients. So I really enjoyed that. The second comment is I love the word, I love the phrase phenotype-genotype correlation. I also like DAMPs and toll light receptors a lot, I think that is also another future of direction of how we're going to care for our patients, is that you've highlighted that some patients, historically we classify them through their clinical syndrome and their symptoms, but there are definitely subtypes of these patients that would warrant the in-depth diagnostics, because again, the goal is this precision medicine. If you understand the specific pathways, there may be drugs that are available or being developed or in clinical studies that may be useful for your patients. So that's really interesting. And again, I'm coming from clinical immunology, which a bit biased as well. I feel like everybody has some kind of immune defect or dysregulation in many of our diseases. But anyways, I really enjoyed your presentation.
Oh, thank you very much for that comment. And this is really the pitch I want to make here, is that we have to stop thinking in silos. Certainly, I mean, there is some standard patients who are just rheumatology patients, but there are many patients where we cannot think in silos, and we can, form formal teams, but at the end of the day, it's really just a matter of your thinking. And if you stop thinking that, oh, I'm the rheumatologist and I'm this one and this one, then you've already taken that first step. For example, imaging. I do ultrasound, and there have been these conflicts in the past where people say, no, imaging is with radiology. No, there is imaging experts in various areas of this hospital, and they should come together and they should work together as a team. And for these patients, again, we all have to take ownership. The worst thing that can happen in an institution like ours is that a patient is being seen by various subspecialties, and everybody says, oh, well, that's not really my domain. I mean, this is a rheumatology patient, or that's not really mine, that's a GI patient. For these patients, we have to stop thinking like that. We have to start thinking as interdisciplinary teams who take care of that patient. And if we change that mindset, and if we take ownership together for these patients, then I think we'll have better outcomes and better care for these patients.
I just ask one, Mona, could I just ask one quick final one? What do you do with the next patient that comes along like this, Johannes, knowing what might have happened from the drug? What is your approach? And a brilliant talk, by the way. So
thank you, Alex. So as I said, nothing has changed in the way we use those drugs. We still use them every week, essentially, because the alternative, there are no good alternatives. The alternative is steroids, and that's not a good alternative. And most of the patients don't go into this complication. And it's not clear that these drugs absolutely cause this. I mean, there is probably another trigger here, and maybe there is another genetic or whatever predisposition in this patient to make them go down that route. So we're not changing it, but we are certainly aware of it, and we need to be aware of these ominous signs. And moving forward in the future, of course, I do think that we may be using more molecular techniques from the get-go. I always envy the hematologists and oncologists. When you get a certain cancer, even decades ago, they would test for resistance to certain medications before they actually apply chemotherapy. We've got nothing like that in rheumatology. So Alex, you need to work harder in your lab. Really, we're waiting for you to give us better results. I mean, I'm disappointed, Alex.
We cloned one of the original genes, NAPE genes, in that whole pathway, but we misidentified what the function was. So we will work harder. We will work harder.
Please work harder, Alex.
Okay, back to the lab for you, Alex. And thank you again, Johannes, for a really fantastic presentation. You gave us the benefit of the learning and the experience of walking this patient's journey with the patient and the family. Very complicated situation for so many reasons, and we really appreciate that. Thank you.
Great job.
Thank you all.
Bye.